Good evening, friends. Uh, if in India we wanted to choose a very popular epidemiologist today or a man of science, then probably, undoubtedly, that honor would go to Alfred Hitchcock because the entire country is in a kind of Hitchcockian suspense and is reliving the question umpteen number of times every day that what is the state of the pandemic after being bashed around badly quite a few times, that we still remain in the awe of what's happening in the country overall, what's happening in the states, and do we get to confront another monstrous third wave, etc., etc. But behind answering all these questions is the science of the pandemic. And behind monitoring the pandemic, we have scientists, people in public health. We have people in the field of epidemiology, virology, data sciences, who've been working incessantly on this subject for the good part of last 2 years. And today, as we've really had a flood of opinions, we've had a flood of expert opinions, and this evening we are going to hear from the experts themselves who've been intently and absolutely assiduously involved in gathering, measuring the data. And as we know, the message for this evening, the central theme for this evening is going to be that how do we get to plan out the data? How do we get to get a grip of the measurement so that we can come to terms with the pandemic and have logical ways of countering it? And I'm so happy that we are joined by a panel of four very eminent people today. And first of all, I introduce from Kolkata, my friend, colleague, a friend surgeon. You know, we are both of us. I cut the heart, and Dipendra is a very accomplished professor uh, of cancer and oncosurgery and breast diseases from SSKM Hospital, who's also done a lot of public awareness and speaking on the subject. So, Dipendra, welcome to the session. And Dipendra, as it happens, Dipendra has got a pretty important case that he could not defer this evening lined up, so he will be with us briefly. And join amongst the faculty, the speakers who've joined us already. We have Dr. Manoj Muhrekar, we have Dr.Nimpathy, we have Dr. Samiran Panda, and of course, the very person without whom we would not organize the session this evening, our very own and very dear Dr. Swarup Sarkar, who's been the mentor, who's been the driving force in getting a discussion and an evening like this organized. Dipendra, what do you expect from the session this evening? Let's have your opening comments.
I, I strongly feel that uh, we are looking at how the pandemic, what's the likely picture in next 6 months, and where we are looking at the quote unquote word called the end. And that's what public is also looking for. And we also are looking at and trying to speculate things. And hopefully, after the end of today's session, we'll be able to visualize at least something which is more clear and less gray.
So you, I think, very unambiguously, you have put the ball in the court of our speakers, and you want them to come up with a clear view of the picture of the future, if there is one. I'm not sure there is one. And on that note, I think we welcome our first speaker for this evening, Dr. Manoj Muhrekar. Dr. Muhrekar is going to speak to us about the current efforts in data collection and data generation. He's one of the main authors and one of the key people who've been behind the four national sero surveys, which gets quoted, thousands and thousands of times in all kinds of popular and semi-scientific discourse. So why not this evening we hear from the person himself who's been the center of giving us an idea of the depth of water as it stands today, Dr. Muhrekar.
Thank
Sir,
you,
please.
Dr. Sarkar. Thank you, Dr. Sarkar. I hope you can hear me.
we can, sir.
Yeah. So, well, at the outset, I want to thank you as well as Sarubda for inviting me to talk about the national COVID zero surveys that were conducted by ICMR. I hope you can see my slides.
We can, yeah.
Yeah. Okay. So, let me briefly tell you the use of zero surveys in the context of COVID-19. As we all know, in India, in all the districts, facility-based surveillance for COVID-19 is happening, where suspected COVID-19 patients are tested with RT-PCR or with rapid antigen test. And this surveillance data can tell us about the trend of COVID-19 epidemic in the district or in the state. But this surveillance is influenced by several factors, such as the testing strategy of the district, also about the number of tests that are conducted in the district. And we know that many districts are not doing adequate testing, and therefore this facility-based surveillance data might not be very reliable. So different types of tests are also used in different districts, and their sensitivity varies, and that is another factor which affects our facility-based surveillance. And very importantly, we know that most of the COVID-19 cases are are either mild or are asymptomatic, and such patients are less likely to attend or detected by facility-based surveillance. And in that context, sero surveys are very important. They can reliably tell about the extent of spread of COVID-19 infection in the country. So, in fact, sero surveys can help us answer two important questions. First is what proportion of population have antibodies against SARS-CoV-2, and prior to vaccination, these antibodies were primarily due to COVID-19 infection and natural infection, whereas now after vaccination, these antibodies could be also on account of vaccine. And the second important question that sero surveys can answer is what proportion of population is immune. But this question can be answered with certain limitations, and I will talk about these limitations when I talk about the inferences that can be drawn from the sero survey findings. So ICMR conducted four national sero surveys till now. The first was done during May-June 2020 when the country was in lockdown. The second was during August-September 2020 when we were at the peak of the epidemic. The third was at the end of the first wave, that is in December 2020 and January 2021. And the last sero survey we recently completed when we had the severe second wave of COVID-19 in India. The objectives of this survey was to estimate the age-specific seroprevalence of COVID-19 antibodies in the population. And we also identified certain socio-demographic risk factors associated with seropositivity. And we also estimated the infection to case ratio, that is how many infections per reported COVID-19 case at a national level. And by doing these serial sero surveys, we were able to measure the trend of infection in the country. Very briefly, what did we do as a part of these sero surveys? So these sero surveys were conducted in 70 randomly selected districts across the country from 21 Indian states. And from each of the districts, we selected 10 clusters, that is villages in case of rural areas, and wards in case of urban areas, by a method called as population proportion to size method. And then from each of these village or ward, the survey team selected 4 random starting points. And from each random starting point, they selected 10 individuals who consented to participate in the survey. And thereby, we selected 40 individuals from each cluster and 400 individuals from each district. Now, the first sero survey was conducted only among adults, that is, individuals who are aged more than 18 years, and these individuals were selected by simple random sampling. In the second and third sero survey, we expanded the age group. We included individuals who are aged more than 10 years. And from in the fourth sero survey, we further expanded the age group for sero survey. So we included individuals aged more than or equal to 6 years. So what we also did was from each random starting point, we selected one child who was aged 6 to 9 years, two children who are aged 10 to 17 years, and seven individuals who are aged more than 18 years. And by selecting this number of individuals, we ensured the proportion of individuals in this age group comparable to that of census population. So we collected blood samples from consenting individuals and tested for IgG antibodies, and we used different tests at in different surveys. In first sero survey at that time, the only indigenous test that was available with us was a COVID Kavach ELISA that was developed by NIV Pune. And since this particular test has lower specificity, we tested all the positive samples with another ELISA which detected antibodies against S1 protein of SARS-CoV-2 virus. In the second sero survey, we used a CLIA platform, the chemiluminescence immunoassay platform, and we detected IgG antibodies against nucleocapsid protein of the virus. In the third sero survey, by that time, we had information that nucleocapsid antibodies declined faster, and therefore we tested sera for both antibodies against nucleocapsid as well as antibodies against S1 protein. And the same thing, tests were done or adopted in the fourth sero survey. But this time we had an option of using quantitative assay, wherein we estimated the exact titer of antibodies among the participants. So this slide summarizes the number of districts, number of clusters, and number of individuals that were enrolled in 4 sero surveys. So we, as I mentioned, we conducted the sero survey in 70 of the 736 districts in India. And from each district, we selected 10 clusters, that is 700 clusters altogether. About 25% of these clusters were from urban areas. And overall participation rate, if you see the last row, ranged from 81% to 92.5% in different sero surveys. This slide summarizes the seroprevalence of SARS-CoV-2 antibodies at different time points. So in April, it was 0.73 and it increased to 67.6% by July, August by the fourth sero survey. So let us see these findings in the context of the COVID-19 epidemic in the country. So in April, only less than 1% of the population had antibodies, and it was very consistent with the early phase of pandemic in the country. By the beginning of, or by the middle of the pandemic, about 7% of the population was infected. And by December, when the first wave declined, about 25% of the population had antibodies against SARS-CoV. Meaning that remaining 75% of the population was not exposed, was seronegative, and was susceptible to infection. And that is what was evident in the second wave, which was we had a very severe second wave, which was driven primarily by susceptibility of the population, as well as the very highly transmissible Delta variant that was circulating at the time in the country. And at the end of the second wave, nearly two-thirds of India's population had antibodies against SARS-CoV-2. Now, this sero survey was conducted or gave a picture of seropositivity at the national level, and it was not designed to capture the variation in seropositivity within the district or within the state. So if you see the seropositivity by state, it ranged from 79% in Madhya Pradesh to 44% in Kerala. Again, within the district, there was wide variation. And in Ernakulam district in Kerala, only 40, the seroprevalence or seropositivity was 40%, as against 86% in Buxar district in Bihar. In West Bengal, we sampled 5 districts, and in these districts, the positivity ranged from 54% in East Midnapur to 67% in Bankura. This slide summarizes the seroprevalence by age group. And if you see, I'm not presenting the findings of first sero survey because the positivity at that time was less than 1%. So in subsequent slides, I will be presenting the findings by findings in the 3 sero surveys, the second, third, and fourth sero survey. So as you can see in the second sero survey, less than 7% of the population was seropositive, and the seropositivity did not differ by age group. And same hold true for the third sero survey, except that individuals aged 18 to 44 had a slightly lower seroprevalence. But interesting finding is during the fourth sero survey, we found the seroprevalence increased with age, reaching nearly 80% among individuals who are aged 45 to 60 years and more than 60 years. And if you see very young children, that is 6 to 9 years, nearly 60% of them had antibodies. And overall, if you see 6 to 9 and 10 to 17 years old children, nearly 60% of them had antibodies. And we know that this age group is still not targeted for vaccination, and therefore the antibodies among them was because of natural infection. This slide shows the seroprevalence by sex, and in all the sero surveys, the seroprevalence did not differ among by sex. It was comparable in male and female. This slide shows the seroprevalence by area of residence, and as you can see in second and third sero survey, the seroprevalence was highest among individuals who were residing in urban slum areas, followed by individuals who are residing in urban non-slum areas, and it was lowest in rural areas. So this trend was there in the second as well as in third sero survey. But if you see in the fourth sero survey, this particular distinction or gap by area of residence was fading in this fourth sero survey. It was comparable in all the areas, meaning that in the second wave, the infection has spread substantially in rural areas. So just to summarize the findings from these sero surveys, by June or July 2021, about 2/3 of India's population had antibodies against SARS-CoV-2, and nearly 60% of children aged 6 to 17 years were seropositive. We also found that seroprevalence was similar in rural as well as urban areas. And based on these sero survey findings, we can draw certain inferences about our understanding about the future trajectory of COVID-19 in the country. And before that, we also need to understand something about immunity against SARS-CoV-2. In fact, our understanding of immunity against SARS-CoV-2 that has been evolving, and the current literature indicates that natural SARS-CoV-2 infection produces a robust antibody response, and this neutralizing antibodies against the virus as well as antibodies against S1-RBT last for up to 1 year. That is what the published literature indicates. Beyond that, we don't have data. The studies also indicate that this infection induces long-lived bone marrow plasma cells, which induces antibodies against SARS-CoV-2 if a person gets another infection. Studies also indicate robust cell-mediated immune response following natural infection. And probably because of that, the cases of reinfection are rare, although few cases are reported. And most of the reinfection cases are mild in nature. The published literature also indicates that breakthrough infections following vaccinations are frequent. And because vaccination, in fact, does not prevent infection. But most of the infection among vaccinated individuals are mild in nature. The mortality as well as hospitalization among vaccinated individuals are less frequent. And generally, if you see all the studies, the vaccines are effective against the variants, but these variants, there is a reduced neutralization response against variants among the vaccine recipients. We also don't know how long this infection lasts. We also don't know what is the herd immunity threshold that is required to prevent the transmission. So based on these findings, we can make certain inferences about the future trajectory of COVID-19 in the country. And the first question which Dr. Kunal mentioned is, is there everybody is asking whether there would be a third wave in India. And since by July and August 2021, one third of population the survey district was seronegative, it is reasonable to expect that COVID-19 cases will continue to occur, especially in areas where the seroprevalence was low. And as I also mentioned, that serosurvey was not designed to capture variations within the districts and within the states. The serosurvey captured the overall picture of population immunity at a national level. We need to generate local data about seroprevalence at local level. And I know that several states have planned serosurveys to estimate the seroprevalence at the district level. And I know that in states like Tamil Nadu, they have completed a state level survey. So since cases are now likely to continue, especially in low prevalence area, we must continue non-pharmaceutical interventions, especially use of masks, as well as we must avoid gatherings, and low seroprevalence districts should be prioritized for vaccination. And several states are also are preparing for their third wave. And these preparedness activities should be targeted or should be focused in districts where seroprevalence is low. And these preparedness activities include strengthening or enhancing the bed capacity, especially the oxygen bed, as well as strengthening the human resources in these. The second important inference is about magnitude of third wave. And again, everybody is asking this question, how big this third wave would be. So if you see the seroprevalence at the end of second wave, about 3/4 of India's population was seronegative. And as against in July 2021, only one third of the population is seronegative. So we therefore can infer that the surge of cases is likely to be lower than the third wave. Again, we can talk only about national level from the Sero survey data, and therefore we need to generate more local data to precisely tell as to what would be the trajectory of epidemic. So this high zero prevalence that we found in our national survey is certainly a ray of hope, but it should not be there should not be a room for complacency. We must follow non-pharmaceutical interventions. And we also know that this virus is continuously mutating, and there is a possibility of emergence of variants. And if immune escape variant arises, if number of cases can suddenly increase. And therefore, there is a need to continuously monitor the emergence of VOCs. We need to strengthen the surveillance for molecular analysis of VOCs. The third important question that has been asked is, will children be affected more? And several people, in fact, have predicted that children will be affected more in subsequent waves. But generally, if you see, most of the infection in children are either mild or asymptomatic in nature. And this is not only the Indian data, but if you see data across the countries, most infections in children are mild. And our serosurvey data also indicate that about 60% of children had antibodies against SARS-CoV-2, despite the fact that vaccination has not yet been opened for children. So it is therefore reasonable to believe that subsequent waves might not disproportionately affect children. And therefore, we also should now think about opening schools, because for the last 18 months, schools have been closed. and which has negatively impacted our school children, and therefore we can consider opening schools by vaccinating teachers and vaccinating support staff. So thank you very much, and I'll be very happy to take any questions.
Dr. Muhrekar, thank you very much. I think I'll give Dipendra a few minutes because he threatens to leave us as his case gets ready in the operating theatre. Dipendra, let's take a few comments, or if you have any questions for Dr. Muhrekar.
Well, Dr. Muhrekar, that was really a wonderful educative talk, and you have enlightened us wonderfully. I would like to raise certain issues. Now, I would like to quote two important studies. In one, it was well established that the natural immunity or the immunoglobulin status would tend to continue for 300 days. Around 90% of the immunity will remain static. That was the study which came out from the US. But at the same time, there was another study which came out from Tokyo which suggested that in asymptomatics, it might wane off to 25% of the original social IgG level. So, can we at this point of time make a comment that a natural infection in an asymptomatic, the immune status is going to last for a year?
Well, as I mentioned, our knowledge about immunity to SARS-CoV-2 is evolving basically, and as you rightly mentioned, the paper in Science indicated that this protection or the antibodies could last for at least 1 year. We also know that the individuals who are asymptomatically infected, the antibodies decline faster as compared to those who had symptomatic infection. So what basically we can draw from these findings is that first thing is that we must therefore vaccinate the adult population, and we know that vaccine is available for adult population, so that we need to continue. And second thing is that we also know that among the vaccinated individuals as well as those who had previous infection, the next infection is either going to be very, very rare or it is going to be mild. So we must vaccinate our population. I think that is the key message that I would say. But again, how long the immunity among the asymptomatic individual lasts, we need to wait till additional data comes is available.
There is another.
Please, Dipendra.
Yeah, I was wondering if you have any data about the Dharavi immune status and the Delhi immune status, because last time, of course, that was not part of the national sero survey, but one company data which suggested that after the first wave in Delhi, it was close to 55%. Whereas I am sure that must be a very biased data that they have suggested. But having said that, does that in any way indicate that things can really be temporary in a large group of people?
Yeah, if you really see the Lancet Global Health paper on Dharavi last year, and in fact this survey was done only in slum areas. It was not representative of Mumbai as such, and where we found very high seroprevalence. And as you rightly mentioned, even in Delhi, even if you consider 50-55% of the population was seropositive, a large proportion of population still was seronegative. I mean, for a size of Delhi's population, if 50% of population is still seronegative, you can get large number of infection, and especially when a new variant comes, which is highly transmissible like a Delta variant, we are going to get more cases, and that is what was seen in the last wave that we saw in Delhi. Having said that, I also want to quote an example from Chennai. In fact, here also there are some. We did in fact 3 sero surveys in Chennai, and in the second sero survey, that is after the end of the first wave, the slum population had a very high number of a very high seroprevalence, and in fact, and in the second wave, we didn't get as the incidence was much lower in these in areas where the seroprevalence was higher. So again, meaning that people who got infection in the first wave, it will offer some amount of protection against the second wave or against the new.
Thank you, Dr. Muhrekar. Dipendra, if possible, please hang on. It's really. I think we are just getting it under the skin of the subject. Wonderful, wonderful insight, Dr. Muhrekar. Can I just ask you? Probably we will revisit this issue later when the dynamics and other things are discussed. That with the R number being pushed astronomically high with the emergence of the Delta variant, uh, uh, there are comments, which stupid people like us cannot differentiate, which is said that it has completely hit the herd immunity concept out of the window. It doesn't, because if you are playing around with an R number of in excess of 5, etc., then probably herd immunity does not exist. You've got to go and have antibodies in everybody. Is that what you
Yeah.
think so far? Uh,
Yeah, I mean, last year when R0 was or the threshold was estimated for the herd immunity threshold was estimated, it was something around 67% based on R0 of about 2.5 to 3. Now with the Delta variant, which has a higher transmissibility, it is estimated that the herd immunity threshold that will be required would be about in excess of 85%. And certainly we are nowhere near to that. Even the Sero survey findings only say 67.
sure.
But the gap is much less. Now, if you see at the end of the first wave, where only 24 or 25% of the people were infected, and herd immunity threshold that which was required was much higher, like 67% or 80% in case of Delta. The gap is much less, and therefore we won't see. We will definitely see more number of cases in coming days, but the peak will not be as high as the second wave. That is what we are trying to infer from the Sero survey findings.
May every word of what you say come out to be true. And thank you again.
Thank you.
Please be with us, because I'm
Thank you.
sure there are a lot of interrelated questions in a short while. Thank you again, Dr. Muhrekar.
Thank you.
And with that, it's a great pleasure that Dr. Nimpathy from the Imperial College, who's really gone out of his way to spare time for us this evening, and Dr. Pathy, who's an assistant professor at the Imperial College, is going to speak to us on dynamics of the epidemic, analysis and lessons from the pandemic. First of all, a huge thank you to you, Dr. Pathy, for sparing your time, and please start. Thanks.
Thanks very
Just a
much, Dr.
small,
Kunal. Yes. Did somebody intervene?
yes,
No, I
I
think we are
said,
fine.
Neem, I thought you were now associate professor there, isn't it?
That's
Oh, right.
correct. Yeah.
My
Just a
apologies.
just a small detail. Thank you very much, Swarup.
My apologies.
Um,
Yes.
no worries. I hope my slides are visible and I'm audible.
Your slides are well seen. Please start.
Fantastic. So first of all, thank you very much to the organizers for the opportunity to join you today for this discussion. I'm presenting some of this on behalf of this modeling unit called CHROMIC, which is based at ICMR, standing for Collaborative Health Research and Modeling. As I say, this is based centrally at ICMR, but also with the involvement of Imperial College London. So just to take you back to the picture that Dr. Manoj just showed, this is going to be a very familiar picture for folks by now, showing the emergence of the first wave of COVID-19 in India, followed by the much bigger, much more overwhelming second wave. And as much as we're talking about local data for action here and thinking about how different settings within the country might vary from each other, it's also quite interesting to look back and think about how the epidemic in the country as a whole varied from other countries. And so in particular, when we look at the first wave that happened in 2020, and this peaked at around mid-September of that year. And the really interesting thing about this first wave was that when we think about headlines coming out of Italy, the UK, and the USA, particularly New York City, for example, the experience in India was relatively mild. And so we've heard already about the R number, the basic reproduction number. This gives you some sort of idea of the transmission potential of the virus. And this was estimated around 1.2 to 1.4. So my colleague, Dr. Sandeep, will talk a bit more later on about the meaning of the reproduction number. But for now, but just bear in mind that it gives you an idea of transmission potential. So you need an R0 of greater than 1 in order to cause an epidemic. So you can see that the first wave really didn't have that high a value of R0. And also transmission was pretty patchy. So when we looked at data from contact tracing studies, for example, a constant pattern that was coming through, and this was in India, this was in other countries too, was that there were many, many people who were positive with coronavirus, but they didn't show any evidence of infecting other people. And on the other hand, there were very few people who were infected with the coronavirus, but who had evidence of infecting many, many other people. And so there was a small proportion of individuals who really accounted for a large proportion of transmission. And as you saw in Dr. Manoj's slide earlier, the rural areas saw substantially less infection than the urban areas. So for the second seroprevalence survey that was conducted near the peak of that first wave, we saw that there was roughly around half the exposure in rural areas compared to urban areas. So if we look at the second wave, I mean, this was a very different creature. So as we know, the reproduction number was much higher, and we estimate this to be around 2, 2.5 to 3. And by contrast, transmission was much more intense. And now, anecdotally at least, we saw that whole households were getting infected. And of course, as we saw also in the previous talk, that rural areas were much more affected than in the first wave, and now had a similar level of exposure as urban settings. And so, of course, we know now that the reason for this difference is the emergence of the Delta variant that emerged at around the beginning of the year. So I just wanted to take a step back. I mean, we mentioned herd immunity briefly in the discussion just now, but just to help folks understand what it is we are talking about when we think about herd immunity, I find it helpful to compare an epidemic to a fire, for example. So when we think back to learning about fires in the first place, we've all learned that there are 3 ingredients that you need for a fire. On the one hand, you need a flammable fuel that is available to burn. Secondly, you need a gas, oxygen, in order to support the burning. And finally, of course, you need a spark to actually start the fire, the actual flame itself. And in a way, infectious diseases, and including COVID-19, are quite similar. So, for example, the causative agent of this fire is, of course, the infectious virus. The oxygen, if you like, the permissive environment is the continuing infectious contacts between individuals. And finally, the fuel themselves are the susceptible people. And so you can see from this, the fewer the susceptible people there are, the more you can reduce the number of susceptible people, the more you can reduce the amount of fuel available for the fire. And it turns out for an infectious disease, there comes a point where you can remove enough susceptible people that the fire can't burn anymore. And that is basically the herd immunity threshold. And thankfully, we now have tools with which we can reduce the susceptibility. So vaccination in the case of removing the fuel for the fire, but also what we call non-pharmaceutical measures like face masks and social distancing for, if you like, taking away the oxygen, taking away the opportunity for infectious contact. So as epidemiologists, we often think about, how much do we need to reduce susceptibility, or how much fuel do we need to remove? And as you just heard in the discussion just now, this depends largely on how infectious the virus is, and again, dependent on the basic reproduction number. So you've heard about this general presumption that in the early days of the epidemic in India, that around 60-65% of people would need to be immune. But of course, the Delta variant has changed these calculations and is now expected this to be 80-85% and upwards. But I think one important thing to remember about herd immunity is that we often talk about it as though it's a sort of finish line. You know, we arrive at herd immunity and then suddenly the epidemic would be over. But we have to remember the Delta variant emerged. It showed some potential to reinfect people. It is not that common, but there is the potential. And also with potentially future variants as well, there is also the potential that these variants would have immune escape. And so whatever herd immunity we have right now, we have to think of this rather than a finish line, we have to think of this as basically a level of protective immunity in the population that can act to mitigate any future waves. It can act to reduce the risk of future spread of the virus rather than interrupting the fire altogether. And personally, I think that the most likely scenario is that we're not actually going to be eliminating this virus in the long term. And so at some point in the future, I think all of us will face the risk of being infected with COVID-19. But the important thing is that by that time, we would have enough immunity that this is no longer a severe virus. And we're talking instead about, if you like, a domesticated virus that is much more mild. So I think it's important to remember, we don't often discuss these. We already have coronaviruses circulating in the human population, and these are basically the cause of, for example, the common cold. And so one likely trajectory in future is that COVID-19 could over time evolve to become, if you like, one of these domesticated viruses. So just coming briefly to vaccination, this is a really nice picture from using UK data, and this is basically in response to the vaccination program in the UK. So this was published in The Economist a few weeks ago, but I still think it tells a really interesting story. So on the left-hand side, this is basically new infections of SARS-CoV-2, the virus that causes COVID-19 in the UK. And you can see here this big peak that we had in the winter of around January, February 2021. This shaded area basically shows you the lockdown measures. And so as a result of those lockdown measures, infection went down. And this first orange bar basically shows you the start of the vaccination program in the UK. So it was a very intensive, very rapid coverage. And what we found was that by the time of the second orange bar, basically, there was over 95% coverage of those over 65. They had received at least one vaccine dose. And then you can see once restrictions are eased, there was a very sudden increase in infection in the UK. And so thankfully, this increase in infection has since leveled off. But at the time, this was a very scary increase because we were worried about the potential effect on hospitalizations. But if we look at hospital admissions instead, so this is hospital admissions, and these are new deaths here. You can see here there's a winter wave, again, a very scary winter peak. Infection came down, but the hospitalizations came down, but they came up again, but they did not come up to anywhere near the same levels as the transmission was. And you look at the new deaths as well, the mortality coming from this, and also the mortality was also very muted in this subsequent wave. And so what we were seeing overall in this was that people were getting infected, but they were not being hospitalized and they were not dying from the virus. And of course, this was evidence at the population level of the impact of vaccination in protecting the population. Now, in the UK, we have a population of upwards of 65 million people. Of course, in India, we're talking about around 1.3 billion people. Vaccinating a country of that size is a totally different proposition to a much smaller country in the UK. But what we hope is over time, as the vaccination program develops and vaccinates more and more people, we start to see this level of protection in India as well. So again, reasons to imagine that there will be a milder spread of the virus in future. So just very briefly before I conclude, I just wanted to think a little bit about where we are now. So this is basically showing case counts in India as of the second wave. And so at the present moment, we're basically at the tail of this epidemic. And I think at the last count, roughly 30 to 40,000 cases had been reported as a daily count. And so you can see here that at the moment we haven't yet come down to the levels of infection that really low levels of infection that we saw towards the beginning of this year, and this is before the emergence of the second wave. And so partly this is because of the state level pictures. And so many folks will be aware of the ongoing level of transmission in, for example, states like Kerala, as well as even in Maharashtra, where there's been a very dramatic decline, and infections continue to decline. It seems to be have now settled down to a rather slow decline over time. Kerala, I think, is a very interesting example. For one thing, this is a state that is testing many more people than states elsewhere. But also, of course, as we know, the state had, with some success, controlled transmission during the earlier waves of infection in the state. And I think you can see evidence of that. So in Dr. Manoj's slides, he showed the variation of seroprevalence by different states. And you could see all the way at the bottom at around 40% was Kerala. So of course, the survey wasn't designed to look at the differences by state, but I think it's still very instructive at the, if you like, the reduced exposure that had been achieved in Kerala as a result of the interventions there. If we think back to the burning fire analogy, if you like, there's still a lot of fuel in Kerala. There are still many susceptible individuals, more so than in the rest of the country. And so, especially for these settings that have previously controlled transmission very successfully, there's really an imperative to continue these efforts and to continue to suppress transmission as much as possible. So just to conclude, I agree that there are reasons for optimism, but this has to be cautious optimism right now. For one thing, the vaccination works, at least against currently circulating strains. And from the existing levels of spread, this is something that Dr. Sandeep will talk a little bit more about next. It seems unlikely at the moment that a severe third wave would happen at the national level. And there's a but to all of this. And part of the but is to remember that herd immunity is not a finish line. It's a complex phenomenon. And to some extent, it could be a shifting goalpost, especially when we see the emergence of new, potentially immune escape variants as well. And as we expect to be reinfected with milder versions of the virus in future. As we can see from the examples from Kerala and Maharashtra, that ongoing infection in these states, it really highlights that the virus has not gone away entirely. And certainly low seroprevalence districts and states could be vulnerable to third waves. But really, at the moment, the thing to remember is always that prevention is better than cure, and we have effective tools for prevention. And this includes vaccination, as well as non-pharmaceutical measures such as mask use. And these will be essential in managing future risks. And with that, thank you very much.
Thanks so much, Dr. Pathy. That was very lucid. I'll definitely invite in Dipendra, who I think is getting very ready to get into the theater. Can I just ask you, a kind of a reverse logic question? That you see at the end of the first wave, which peaked sometime in September and reached its nadir for India, it reached its kind of nadir sometime in February. I think it came down all the way as low as 3,000, something around that. And then we were hit by the blast of the second wave. So just by reverse logic, the mere fact that we are hovering around 30,000, etc., is that a good thing or a bad thing? So that's question number one. And question number two is, you see, Kerala, I don't know how they managed it. They have slightly better vaccination rates of all the states of India. They seem to have nearly 20% of people who've received 2 doses. I don't know how they did that, but they claim to have done it. But that somehow doesn't seem to reflect in the sort of constant outpouring of cases that is coming out of there. So just 2 quick comments on these 2 things.
Great. So on the conclusion of not conclusion, but the tail end of the second wave, and this slow decline, I like to think of it in terms of R0. And as I mentioned, Dr. Sandeep will tell us a bit more about what R0 actually means. But what I mentioned previously was that you need R0 of at least 1 in order to have an epidemic growth. And it seems to me as though the situation that we're in at the moment is that we've reduced or not, perhaps as a result of prior immunity in the population, perhaps as a result of continuing COVID-appropriate behaviors in the population, but we've reduced it to around 0.9, 0.95. This is just below the threshold. And we're in conditions where whatever we're doing in order to control infection are enough in order to bring the epidemic down, but not in order to eliminate infection altogether. And so we're going to be seeing these continuing level of low-lying infection. So from that point of view, perhaps this is not a great sign, but again, relating to the topic of today's discussion, we really need hyperlocal surveillance in order to know which are the parts of the country, and even amongst those states, which are the parts of the states that are most contributing towards this ongoing caseload. So that will be a continuing need. In terms of vaccination, I personally, am not surprised to see such levels of coverage. And on the country level, for those double doses of vaccination, I think the last estimate that I saw was around 8 to 10% had been double dose of vaccination. Right, and in Kerala, of course, much higher. So that's not necessarily to say that vaccination alone will reduce the levels of transmission. Certainly, at those levels, at 20% is not going to do so. And in response to the Delta variant, really, we only have protective immunity when you have double dose immunity and not just single dose immunity. And so. Hopefully we'll start to see an escalation in the vaccination coverage. And my feeling is that once we start to get up to 60% vaccination coverage, we're not yet at the herd immunity threshold, but we're at a point at which we can actually start to affect transmission to the extent we hope we would.
Fair comment, thanks. Dipendra, any questions from your side?
And I would ask a question to Mr. Nim. Now, number one is, if we look at the whole spectrum of how the pandemic is going, I mean, in the forefront, I mean, towards the last end of the spectrum or the lowest end of the tail is the United Kingdom. And Kerala is somewhere in between United Kingdom and what rest of India sees. I mean, in Kerala, it's a population of 3.45 crore. And if we subtract 88 lakhs, that's the population above the age of 18 years. So it's 2.5 crore. And they have vaccinated 2.1 crore of their population. That means they have got almost close to 70% of the adult population getting at least one dose of vaccine. And therefore, they are having at times 23,000 cases a day with the hospital admissions absolutely not filling up. So I think that makes sense that we are on a trajectory where Kerala is somewhere in between. It's not actually the number of cases that we are concerned, but the number of hospitalizations. And as the pandemic progresses, we are looking at what percentage of people are dying rather than how many people are affected. So this is my comment, and I would like to ask Mr. Nim, now what is the scenario like in the United Kingdom? While there was the second wave, was it in the same region where the first wave was having, or the second was having tremendous, that in the same region the third wave came, or it was a different zone altogether where it started from Bolton and started flourishing?
So we saw something analogous to India, for example, in the second wave. So there you saw a case where Maharashtra, Delhi, for example, the metro areas, they were hardest hit in the first wave, and they were amongst the first affected in the second wave as well. And so we also saw similar patterns of infection here in the UK, even in the third wave. So London, which is where I'm based at the moment, was amongst the most affected even in the third wave. I have to say the third wave itself has been the most much more muted than people had feared, and there's still a lot of discussion about why that has been the case. Any number of reasons have been put forward, but we haven't necessarily seen infection moving around the country as you might expect in other settings.
Thank you so much. Thank you so much, Dr. Pathy. I think we are perhaps sort of being a little pressed for time. So you have made a very strong case for local data to be obtained because not every compartment or every segment of a state is going to follow the behavior as we think, on a larger pattern. Can I, at this point, ask for his synoptic comments, and then we will take in the comments of each panelist if they have any supplementary remarks to make from Swarupda, Dr. Swarup Sarkar. Swarupda, please.
So what is happening is there is no substitute for the local data, and more I'm happy to know that the West Bengal has started local data. তাহলে কি হবে, and the advantage would be in some parts of the country there may be lockdown, and while in some parts of the other country the schools may be open, market may be open, either possibility has been proven from all these people. We have the tools, we have the technology. What is needed is a political action based on the local data. And I'm happy to see that West Bengal is one of the few first states যারা local data collect করছে. Now, one of the practical implication is, যদি locally, if we see the local data is very low, and the schools can be opened safely with keeping an eye on the number of increasing infection, provided that the teachers are vaccinated as well. One slide I think Muhrekar did not show today. I'm not sure whether Muhrekar has showed that in many places, children and particularly more than 12-year-old children are showing similar set of data, similar set of antibody. So there is no point of treating these two populations differently, which makes a stronger case of opening those schools. But the bottom line is, I think the whole purpose of today's presentation, and thanks to Kunal and your patience, and although some of our slides have not been very for common people, I think one thing we're trying to say that the science exists, the forecasting capacity exists, and based on which there is a huge implication for people whether to take a very stringent step of lockdown to opening everything in that local area would all depend how much local data we have uh, collected. That's the main message I thought it has come out. And if it has not come out, I think the scientists, some of them are very accomplished scientists, would be able to come again. The last point is, which is true for everywhere, because of these uncertainties and the lack of local data, there is no substitute for, we should not be too afraid, neither we should be too complacent. We need to keep at the local data, and based on which we can have a wide range of intervention, starting from opening everything to having a very stringent lockdown. I'll stop here, and then if you think we have some questions, we can take.
Can I just, at this stage, invite supplementary comments from Doctors Muhrekar, Dr. Pathy, that, you've heard through the rest of the discussions. And Dr. Pathy, especially, I have a curiosity to fulfill, which is what kind of experience you've had with local data in UK?
So in the UK, that's a great question. My colleagues at Imperial College have been much more involved with the UK response than I have. But certainly, some of the really prevailing questions and really important questions in the UK have been, how are different regions of the UK being affected?
Sure.
So after our last national lockdown, there certainly wasn't an appetite to return to another national lockdown. And so politically, at least, there seemed to be more, at least a push towards local lockdowns. And so local data was definitely very useful for informing those local control measures. And I think it'll continue to be so. Now, there's still a lot of debate in the UK about whether local lockdowns could work as well, because people just tend to, people are mobile, right? People tend to move out of whatever local restrictions they have. But it's been striking in response to the last wave of COVID in the country, just what a more localized response the whole efforts were shifting towards. But just broadly, in terms of the supplementary comment, we do often talk about local data for local response, but I think we also have to be mindful that sometimes local data can be very useful for the global picture as well. And I'm thinking particularly of genomic surveillance. Now when we are remaining quite vigilant for the emergence of a new variant, being able to monitor these variants of concern at a very fine spatial scale, at a very fine local level, could also be very important in an early warning of the emergence of new variants, so that we can respond as quickly as possible. The earlier we're able to detect these, hopefully the better we'd be able to respond.
Dr. Pathy, just one, sorry.
Muhrekar might have some also local data, but sorry to interrupt, Kunal. You go ahead.
So, what is the current UK rate of genomic studies, genomic analysis of all your positive samples?
I forget offhand, but I know it's one of the countries with the highest rates of sampling.
You're probably in double digits.
Correct.
Maybe.
Yeah.
Maybe. Yes. Yes, Dr. Muhrekar, please.
Yeah, I mean, the local data is very important, and I can quote an example from Tamil Nadu, where we are basically we have a dashboard for a district level data, and then we are collecting data for three primary indicators. One is weekly change in incidence of COVID-19 cases. Second is test positivity in each district, and third is bed occupancy in each district. So based on that, we have basically categorized each district into green, yellow. So this data is now monitored, and each district is basically is categorized into different zones. So that will be very useful to find out where whether there is an increase in number of cases, whether the test positivity is increasing, and stricter action are required. Each level is also associated with enough action is based on test positivity. So that we have implemented, and that dashboard is dynamic. Every week we are updating that dashboard, and state in fact is providing data for updating the dashboard. So that is one example where local data can be used for local action. And as the second point, which as Dr. Swarup mentioned, in fact I showed a slide where the seroprevalence among 6 to 9-year children as well as 10 to 17-year-old children was in excess of 60%, very much comparable to adults. And therefore, we need to consider open schools and